evening, everyone, and I would like to thank the entire organizing team for the inviting me. So, as we've gone through about how reconstruction is an essential part of head neck cancer treatment, and we've seen what happens in the post-operative setting. I'm going to talk a little bit about what are we looking at during the surgery itself. So, any ablative surgery, our goal is to essentially replace all these functions and not just to create a cover but to actually a functional reconstruction. And what we found over the years is that a one size fits all, the approach does not work. And so we try to individualize our approach towards our patients. So, because of free tissue transfer, the possibility of anastomosing vessels that are between 1 to 3 in size or even smaller at times, the whole body becomes a reservoir of flaps which we can use to accomplish our reconstructive goals. So essentially, resection, rehabilitation and reconstruction have to go hand in hand. So we see these kind of reconstructions, lesser and lesser. And we have emerged in our whole, armamentarium of finding flaps that work, that are more safe, predictable, that give function and cosmesis, reduce donor side morbidity, and that's how we finally select our reconstruction. So some of the principles involved these days is not just wound healing and helping the patient to go in for radiation therapy, but to also look at other factors such as function, cosmesis, low donor side morbidity, individualized decision making for the patient themselves, and also to make sure that whatever reconstruction is there, it also has tolerance to radiation. So it's essentially a balance. It's often said plastic surgery is a battle between blood supply, for blood supply. So this is a balance of art and science. And so if we're looking at intraoperatively and we want to look at the defect, but wait, what are the other things we have to ensure before we actually look at the defect? Make sure that your resection team is not coming back to revise margins, and these are your final margins. That the non-anastomotic neck site is closed, drains are placed and secured. The tracheostomy tube is secured and the skin is sutured at the right point. The Riles tube is secured. At times when there is mandible resection involved, we have it's good enough to ask the head neck team to help us with the maxilla-mandibular fixation, so that's one step less for us. Ask them for any event that has happened during the neck dissection. If the EJV has been clipped at a site that you can't really see, but where it joins into the IJV, if they've had to repair any vessel during the neck dissection. Ensure hemostasis, reassess for chyle leak. Then ensure that all the counts are right, and you have like a check for if your counts go wrong, then you know that they've been right till the head neck team left. And call for assistance if required. If you're short of people, just ask one of them to join your team. Now coming to the defect. So assessment of the defect was initially, it was in 2 dimensions, but whenever the third dimension is disregarded or underestimated, this gives rise to a lot of issues. And initially we had technical limitations because of the type of reconstructions we did. However, now, because we have free flaps which we can basically fashion to any defect, this is not a criteria. The next thing we have to look at is all the components that need to be replaced. And based on that, what each component is required for, what is our function and what is our reconstructive goal. So animation is of course something that we want it to happen but may not really achieve. But these are factors that we should always take into consideration. So also while replacing bone, bear in mind that just bridging the bone defect is not our reconstruction, but also achieving dental rehabilitation in this patient is our goal. So now coming to the donor side, and why this is important, especially in Indian patients, like at our center, we get patients from all across the country, and the same donor site may look very different based on where the patients are hailing from and their body morphology. So we can't really say that, okay, for this particular patient or this defect, this is the reconstruction that I'm going to do. And also there is a difference between the proximal and distal part of the same donor site, and this also needs to be kept into account. And this is seen even with bone flaps, that the skin paddle accompanying the bone flap can be of varying thickness. So these are all factors. Ideally, all these should be checked pre-operatively, and you should have a fair idea of what you're going into. But if that is not possible and this is a patient that you've seen with the defect already created, these are things that you should bear in mind. Patients do complain of donor site and skin graft sites. So when you're creating these defects and using various parts of the body as donor sites, we need to be aware of it. The vital thing that is there in head neck reconstruction is that the time to healing should not be indefinite, and your reconstruction has to hold during radiation, because even partial flap necrosis can lead to total treatment failure, and that is not something we want. So as you see, this particular patient, initially one would assume that it is an overestimation of the defect and we filled in too much flap. But as you can see in the subsequent images that the flap, the tolerance to radiation is such that it has just shrunken away, and this is with no secondary procedure done, that the flap has now come to the, what is there in the late postoperative period. So this sort of an estimation intraoperatively is something that one has to bear in mind. What about patients who are at high anesthesia risk but have larger defects, and hence prolonged anesthesia is not a problem? In such cases, of course, you have to pivot. This may not be an ideal reconstruction, but what we needed was cover in this particular lady, and that is what has been achieved. Site-wise management, just for buccal mucosa, these are the various components that we have to take care of, and there are various options in our toolbox. How do we choose what we want? The first and foremost part is to assess what our defect is. A standard buccal mucosa defect means just that the inner mucosal lining is resected. But what about the other components, such as what if this is combined with a marginal mandibulectomy of the lower alveolus, or an upper alveolectomy, or it is a combination of them, of both of them, and the outside skin has also been resected. So as this defect size keeps increasing, it's not only the length of the lining that is required, but also the soft tissue volume that is required to cover these defects. And one must always bear this in mind. Or when you put in a thinner flap or a more pliable flap in a defect like this, you will lead to issues post-operatively. So this is an example of skin graft closure done for buccal mucosa. You can see that the mouth opening is compromised, and there's a contour deformity. However, here a forehead flap which was done, the mouth opening is adequate. However, there is no, the appearance of it is unsightly. Or a PMMC flap that's done where there's too much bulk now in the neck, which was not required in this patient. So these are things that can be avoided. Earlier today, Dr. Prashant did speak about local and pedicle flaps for head and neck reconstruction. And these are things that we use often. However, he also mentioned the little complications or undesirable effects that we see in them. However, if chosen in the right patient, and even for extended indications, there are ways to modify your incision. These are all intraoperative decisions that are taken. You can Doppler your perforators, you can take a incision and actually visualize your perforators and then plan your flap and end up with adequate reconstruction. This is of course only possible in an older woman with pliable skin. Won't be such a great idea in a younger individual. Definitely not an idea in a male patient. For parotidectomy defects, in which we would end up doing a free flap or a spiral PMMC. A submental flap designed in this particular manner was adequate for the reconstruction. However, if a radial forearm was to be done for a buccal mucosa defect, wherein other components have not been addressed, post-radiation, these are the kind of contour deformities that we see. So that is why in our practice, more and more we have reduced the number of free radial forearm flaps that are being done, and we've shifted to more robust flaps, perforator-based flaps. So one of the flaps that we favor most commonly is the anterolateral thigh flap. However, since we do not image our patients due to logistical reasons, we have developed an approach by which we do an anterior non-committal incision. And how does this help us? Is that there are various perforators present in the thigh of the patient, and by taking this anterior non-committal incision, we are able to design various flaps based on the position and the type of perforator that we find. So all these are our options with this particular incision. So we can either harvest an anterolateral thigh flap, anteromedial thigh flap. We use a simple sound Doppler, which is low sensitivity, which I think helps us and doesn't give us false positive results. And therefore, based on various perforators, we are able to shift our flap. Therefore, the reconstruction is always possible from that very donor side, and we don't have to change our plan very drastically. Also, such kind of flaps are amenable to intraoperative thinning, which we can do to size the flap accordingly. And pedicle length is also usually now not an issue for these patients. Lip reconstruction, again, various local flaps that have been described. However, what are we looking at? What are our goals when we try to do lip reconstruction? These are the various types of defects that we encounter. However, application or blind application of certain local flaps leads to pinhole mouth openings such as these, and then you get these patients in their late post-op period, and you have to reconstruct them. I'm focusing more on lip defects that are more extensive, either partial or total reconstruction. You have various options for that. This is an example of a sling being used, palmaris sling being used along with a free radial forearm flap and a reconstruction done. However, in a radial forearm flap done in a similar defect, post-radiation just sunk down and of course was not helping with the mouth seal. In these patients, you have to end up doing a bulky flap which you can secondarily thin and get them to a more acceptable size. This is an example of a carapancic flap in a complication that was there, which we had to recreate the defect and then put a radial forearm flap in order to reconstruct that new defect. So what are the things that we look at? We look at the submucous level of submucous fibrosis, the involvement of the commissures, what is the mouth opening of the patient. We also need to look at whether the fibrous mucosa and there is a temporalis contracture which needs to be released. These are all factors that need to be considered during the intraoperative decision-making process. Dentition of the patient plays a big role, the kind of diet that the patient is on. So if the patient does not have dentition, is fairly on a liquid diet, then we can give them what is called as an acceptable microstomia so that they don't drool and dribble when they take their diet. However, if a dentate patient, we have to make sure that they have a good mouth opening. So this is basically a difference between how to balance competence versus microstomia. Tongue reconstruction, again, we often do see a lot of cases where dynamic reconstruction of the tongue that has been performed, which we've still not found a way to replicate tongue function with any flap that has been described as yet. However, what we try to do is aid the function of the remnant tongue and also to make the patient amenable for speech and swallow therapy, as a result of which they can still deglute a bolus of food and have adequately good speech. So a few examples of what has been done. In this case, we just need a very thin pliable flap so that the remnant tongue can take over the function. Or in cases where a larger resection has been done, our primary function is to seal the floor of mouth, and our secondary function is to make sure that there is bulk created so that the patient can use that to abut with the palate and therefore swallow the food. A case of total glossectomy where a bulky flap is done just to bridge that gap apart from just creating a seal inside the mouth. So when doing these cases, one has to be careful that if the donor side is too bulky, you either switch to a new donor side or you do something intraoperatively to thin the flap, or you do end up into trouble because of during the inset of the flap. And you can see that with this constant contact with saliva, it does get a little mucosalized and such, in some patients more than the others. So it all goes about how much bulk is required, how much of it will eventually stay. Is there any potential benefit of doing a free flap in this patient versus a pedicle flap? Do we have to keep the hired stitch? Does it help? So these are decisions that have to be taken intraoperatively. Pharyngeal reconstruction, again, it's always an SOS call. If there's adequate mucosa left behind, then and primary closure is possible, that is what is done. Or if that mucosa is inadequate, then we switch to a patch flap, which could either be a pedicle or a free flap. Or if there is a total circumferential defect, then we have the option of a skin-lined or a skin-lined flap, which can be tubed, or an intestinal flap. So because most of us in general surgery train, and harvesting an intestinal flap is not something that is new to us, I think we end up preferring an intestinal flap. However, skin-lined flaps also can be done. The donor sides will be a little extensive and that can be avoided, or you can do a thin ALT flap, or else we do something like a free jejunal flap. We recently did a study in the hospital which said that swallowing in speech was a little better when intestinal flaps were used. However, there are a lot of things that we need to take care while using an intestinal flap. The judgment of length in these cases, intestinal flaps have a very short ischemia time, hence performing the anastomosis as quickly as possible even before insetting the flap. And then once you perform the anastomosis and this flap does get some amount of peristalsis, we need to now inset the flap into the floor of mouth and then into the remnant of the esophagus. So doing this, getting a monitoring paddle out, judgment of the length that will be required, judgment of the pedicle length of the monitoring paddle so that it does not pull on your actual anastomosis. These are various things that we need to consider while doing this particular reconstruction. Mandible reconstruction has been covered very thoroughly by sir. Over the years, because of the number of flaps we've done, I think we've just found ways to make our life a little easier. So these are a few things that we've adopted in the hospital with regards to positioning the leg for a free fibula harvest, because these are things that you're doing day in and day out. So ergonomics does play a role eventually in your well-being. Or the fact that we do not consider donor site specificity too aggressively, and we have found ways to manage the left fibula for both both intraoral and extraoral defects in various ways. So how the flap is flipped, and the same flap can be used for anastomosis on both sides of the neck. This is not a hard rule. Of course, there are benefits of using various other flap designs. Earlier when we would use giggly saw, this is a modification that our boss Dr. Prabha Yadav did in order to hold the giggly saw more better while we use it. This is of course her gift to all of us, the fibula holder, which is used for retraction at times when we do not have adequate assistance in the hospital, and it is of course we are all very used to doing this now, that single-handedly one person can retract the fibula during the harvest. Another thing is management of various vascular anomalies or variations that we see. Again, because we do not routinely do CT angio in most of our patients, we do encounter some and because of the high volume of free fibula surgeries that we do encounter these variations, and we found a way to safely harvest the fibula instead of abandoning the donor site and switching onto another site in some cases where it is possible. The other instrument is of course the guide to creating the osteotomies. This is again something that has been a simple design after measurements of various mandibles of Indian patients, that a standard template has been created which is then used for hand-held osteotomies. Of course, with VSP and CAD-CAM, something like this looks very rudimentary, but it's very useful where these facilities are not available. And even somebody who's a beginner, once they understand the concept, it becomes pretty easy to use this and to still manage a good reconstruction using these devices. Of course, now one of the common problems that thankfully we don't encounter as commonly these days is that you have a plan for VSP. You have all the CAD-CAM jigs, the cutting jigs, your fibula cutting jigs, all of it. But now the plan has changed and the resection is increased or the resection is decreased. Each way, you are now potentially going to throw all your planning down the bin. So one way that we found to circumvent this problem is that we always plan for additional osteotomies on either side. So your plan is still viable. You can use those same jigs and end up doing a good reconstruction, even if the resection plan were to change in the last moment. Same thing even in pediatric patients with cantilever fixations. This is one area that we found that CAD-CAM planning or imaging really helps us to site the anterior ramus into the temporomandibular joint. So even though her mandible is only fixed to one side and just anchored to soft tissue on the other side, the girl didn't have any deviation and had adequate mouth opening. So this is an algorithm that we created because of the fact that we started dividing our fibula skin paddles in order to address the intraoral and extraoral defects. And we realized that this is not something that people commonly encounter, and hence to make the whole process easier, an algorithm was created about when we should do what to the fibula skin paddle and the bone, so that all types of bony defects along with soft tissue can be reconstructed successfully. We published this data about the algorithm itself, and we had a fair idea that in this method, the division method did fare better than the de-ephthalization method, and we could actually prove this with a propensity score analysis, which has been published. Now, in maxilla reconstruction, again, beautifully covered by IR sir. So, this is what patients would look like earlier when maxilla reconstruction was not done. The only one thing I had to highlight was this, that of course we weren't told right at the beginning that this was going to be the defect. So, of course, you have to pivot and change your plan. So, we look at essentials, which is to create a seal between the nasal cavity and the oral cavity to give a support to the orbital floor, and that is what we did in this particular patient. This reconstruction in no way is ideal, but as a tide over procedure, this is something that could have been done, that was done, and she could undergo radiation. And now, if she desires, we can obviously do secondary procedures and create her bridge of nose and whatever else other procedures she wants. So, failure of flaps is a reality that the more flaps you do, you will encounter more failures, and these are some of the defects that we encounter. And what do we do at this point? The decision becomes, one is whether you replace them with another pedicle flap or do you replace it with a free flap. And you have various issues such as bleeding, sloughed off vessels, or both vessels are ligated, the presence of orocutaneous fistula, infection everywhere. So you debride everything, you recreate a fresh defect, and you see what best can be done at that point. So it literally acts as a tide over procedure in these patients. They complete radiation and then they can come. Dr. Radhika did speak briefly about vessel selection, and this is exactly our algorithm in these cases. The cephalic flip procedure we have found, again, as she mentioned, is a useful procedure. This is just a video highlighting some of the points where the DP groove in which the vessel is actually dissected. I'm sorry, the video is a little too fast. But some of the points I wanted to highlight was that you do need adequate exposure in these cases. These are salvage procedures. So doing it through limited incisions or curtailing the number of incisions you require is really not your goal at this point. And you have to be careful at the origin of the vein, and then once that is done, you have to make sure that the length of the vein is calculated. So how we do this is again by a very rudimentary method, that we calculate the length of the vein that is required, and we measure the same on the arm of the patient. Because once you're doing the salvage procedure, the last thing you want is the cephalic vein to actually fall short in length. So once that is done, our incision is extended, and the rest of the vein is now harvested. And then in this particular case, I believe we also went searching for the transverse cervical vessels in the neck. Let's come to that. So that is the whole vein that was delivered into the neck, and then we dissected out the transverse cervical vessel, because it's unlikely that this vessel has been used for anything during the neck dissection procedure. And this is a safe vessel which will be ready for use if every other vessel on that side of the neck is not available, and it's a reliable pedicle that we can use. So basically we use a combination of the transverse cervical artery and the flipped cephalic vein as our vein for venous anastomosis. If this is not possible, then the next option is of course to go to the IMA or the IMV on the same side, or use long vein grafts to go to the opposite side of the neck. However, the use of long vein grafts as far as possible should be avoided in head and neck surgery. Managing the kinks and lengths is a whole another process. In cases where we've realized that we need more tissue bulk, we can also go to more unconventional donor sites. For example, in this case, we used the DI flap, which is usually used in women for breast reconstruction, was used for head and neck reconstruction in this patient, which was a failure of a pec major flap. So what do we do as a salvage for a pedicle flap, a free flap for a free flap, or a pedicle flap for a pedicle flap, or a free flap for a pedicle flap? All these options should be open to you. The scalp flap we've seen time and again that comes to our rescue and provides an adequate external skin cover. It's a very robust flap. It's very difficult to damage this flap during harvest, and the donor site is rather hidden because the patient can grow their hair over that, and it's at the vertex where It's not usually seen, and they end up growing a beard over their where the flap is inset, and they tolerate it quite well. In this particular gentleman who had already undergone multiple flap surgeries and had a recurrence, these are not patients in which even the head neck surgeon can tell you what the resection is going to be preoperatively. So all plans should be a go. In this particular patient, we did a combination of an ALT and a scalp flap. What do we do with extensive defects like this? Most of these patients have poor mouth opening. These are fungating growths. There's a lot of induration. It's very difficult to preoperatively predict what's going to be the final resection. Will surgery even benefit these individuals? Should we resect these patients? If resection is done, of course, reconstruction has to be done. And we can't do staged procedures in the hope of an ideal reconstruction. So we look at what is absolutely required, which is lining and soft tissue, and make sure that much is done. Some of the patients that we followed up in which extensive resection has been done, we've had to do 2 flaps, did have up to a year of survival. And so in these cases, which are essentially palliative resections, we found that yes, at times we do decide, okay, let's do these cases till we decide we don't want to, and then we go back to let's do these cases. But now in this era, one of the things that we really need to look at is to minimize donor site morbidity. Taking a flap from anywhere and compromising the donor site is not acceptable. So, for example, earlier where we would take the LD myocutaneous flap, we try and take a perforator-based TDAP flap now, where the muscle and nerve are preserved. But that does not mean our reconstruction has to be inadequate. You have to assess the defect properly, look at various components of the defect that we have to address, and then you can choose to scale up or scale down. You can use the conventional flaps that we've always been using, or you can use the more perforator-based flaps, or which are equally robust but may require a little more dissection and such things. So these are some of the flaps that we have where the donor site is almost absolutely untouched. It undergoes primary closure. The nerves are preserved. There is no loss of function. And even then, we are able to perform with adequate reconstruction in these patients. So a single donor site where we've harvested multiple flaps, however, the nerve has been preserved, and we can use a single donor site for multiple flaps, or perforator-based flaps in which this particular flap can be divided and the various components can be used for various sites. So in this particular patient where donor sites were compromised, what did we do? We went to the back and we managed to get adequate skin and soft tissue from there and could perform this reconstruction. Similar patient, multiple components in her defect. Again, the scapular parascapular flap, helped us in this particular patient. And in this patient, wherein the ALT could not be harvested, and this was an MSAP done for a marginal mandibulectomy with a lip defect and adequate reconstruction. This particular patient where there was a failure of an ALT flap, where a chimeric MSAP with a muscle flap was done, 2 separate anastomoses. The chimeric ALT again is something that we use very often in our practice to address multiple defects. So this is the kind of anatomy that we see. We try and preserve all the nerves, minimize muscle damage as much as possible. Donor site usually undergoes primary closure, and we get this robust skin flaps with adequate soft tissue to get to various areas. And so the tongue is reconstructed, the buccal mucosa is lined, the outside skin is reconstructed, the fat is used to fill the ITF which may keep oozing otherwise. And this is the kind of reconstruction that can be achieved with a single flap or a single donor site. So in a patient post-operative with trismus, orocutaneous fistula, open everything, recreate the defect, again a chimeric pattern flap that has been used for reconstruction. And now this patient has adequate mouth opening. Similarly, a chimeric free radial forearm flap done for a failed submental flap, in which the donor site also had to be addressed. So this particular patient had undergone 2 free fibular flaps. She had recurrences, and finally we did a free radial forearm for post-RT. And it looks a little unsightly. The donor site is not great. However, we were glad to see her resuming her work and using the local training going to work. And that's really the success of our reconstruction. Another way in which the bone and the tongue is addressed with a single donor site, and the outside neck skin also. So these are things that you have to plan on table, make sure what you have in hand and then use it to your benefit. Another example of multiple flaps from a single donor site, a right and left buccal mucosa defect, where the same donor site we created two separate flaps and separate anastomosis was done. Or in this case, an ALT with a TFL perforator flap was used and the same effect was achieved. So this is what you need, this is what you have, do the math, and that's the more and more you push your brain to do this decision making process, the whole process becomes faster, it becomes more logical. You have to keep some caveats in mind and try to do the same thing over and over again so that you achieve expertise in that field rather than going on to an alternate flap or an alternate donor site at each time. So in cases of peroneum magna where there is no goal, the fibula is not an option, it's an extensive defect, then we've switched to using the scapular bone flap in these cases where we can do bony reconstruction along with soft tissue reconstruction with the same flap. And this is the way in which the reconstruction is done, and the patient's donor site is also not heavily affected. What are the things that we have to look at when there is flap failure? Do not give in to your ego. Know that when it's time to quit and do a more, less than ideal reconstruction where the patient's safety is priority. There's always scope to go in and do secondary reconstruction. Make sure that these complications of dislodging of the tracheostomy tube, this now in our hospital we've switched to not removing the nasal intubation till the end of the procedure, even after the tracheostomy is done. Keep looking and monitoring the intraoperative blood pressure. There are often times when there are overs given between people that there is miscalculation of blood loss, which means they have less time, to salvage the patient if there is an event. Insist that post-operative blood pressure and MAP be kept at a high normal level. We are not, we also do have a low threshold to start inotropes in these patients, at least for the first 48 hours. We have seen patients with extensive reconstruction just succumbing to the fact that their blood pressure was not adequate. Intraoperative relaxation is vital. These are long procedures. There is no point of giving any small doses of short-acting anesthesia relaxants because we can't have muscles twitching when you're dissecting a perforator through a muscle. Some things that are essential that should always be in your OR, all your vasodilatory drugs, drugs for anticoagulation, proper instrumentation. These are very, very fine instruments that we use over and over again. And of course, they're going to, fall apart and they need to be maintained first. And when maintenance fails, you have to replace them. Always go for adequate magnification. You won't believe the things you start seeing when you look under a microscope out of your loops. You feel very happy that you're doing a great job. And then when you look at the same thing under a microscope, you realize the truth of it. Have a good synergy with your resection team. One way of avoiding a lot of intraoperative complications with regards to donor site is just pure imaging. If you have the facility or if you're working at a center where you are almost on your own, do image your patient. Use an intraoperative Doppler. Even an intraoperative color Doppler, there will be somebody in the hospital who has it. Ask for it and use it whenever required. Be open about your failures, discuss and learn from each other. And it has been proved time and time again that micro breaks or simple stretching or small bits of sugar highs for operating surgeons have always increased productivity and not really added to surgical time. This is much better than being hypoglycemic and committing a mistake after mistake. Finally, microsurgery is teamwork. Always have people whom you can depend on, and that will just increase the longevity of your career. Thank you.
Thank you, ma'am, for such a wonderful talk on highlighting various complications associated with free flap. Can we have questions?
Peroneum magna type A and B. Just can you highlight if we encounter that during surgery? What do we do? How do we go about it?
So, first of all, today's day and age, please get a CT angio for every patient. Do not be in that fix where you do encounter that sort of a defect. We have salvaged it in ways by which we put long vein grafts and then still harvested the bone, clamped the vessel for some time, looked whether the alternate vessel is perfusing the leg adequately. Most of the times it does, but clamping a vessel and looking at whether the alternate vessel is perfusing the leg, it makes you very happy that it is, but the amount of ischemic damage that the muscles will eventually have is not something that is predictable. So it's best to avoid the situation rather than trying to harvest a leg with a vascular anomaly, a variation.
So A and B also we should abandon, like avoid doing.
Abandon, but
avoid
if you know it pre-operatively, yes. Dr. Prashant, you were saying something.
No, I think, are you doing CT angio for all the patients?
Now, because more of CAD-CAM planning is happening, that's how they end up getting a CT angio for these patients. So
you are combining CAD-CAM with the perforator course.
For a
CT
perforator
angio.
knowledge, so that's what.
So that
because
you can,
it doesn't happen in 100% of our patients. We're nearing just about 50. Not
I have no experience with CT angio and VSP. So, is the course of the perforator actually seen? Like how we dissect during osteotomies, we deroof
So
the
in a
FHL and
higher
see the
slice CT,
perforator?
like a 128 slice CT, they can very clearly correlate where the perforator's origin is and whether it's a muscular cutaneous or a subcutaneous one, from which vessel it's originating, at what level it's originating from the vessel, and at what level it is entering the skin.
Okay.
So this is information that they can readily give us, but if the CT has been taken with that protocol also.
Okay.
The technician has to be aware that we are doing it for this purpose.
Okay.
What's your turnaround time with CT angio and VSP?
So VSP, we actually have a Bangalore-based company doing our work. The fastest they've given us is 5 days to express shipping. So, but usual turnaround time is about 10 days.